So when it comes to your blood work, are you guys basing your training and nutrition off of that, or is that kind of independent?
For the most part, the blood work's going to tell us or help us direct that conversation. And then ultimately will be a back end confirmation if the training and nutrition is actually impacting what the blood work is showing us.
So how often are you checking in on that?
The blood work happens every 3 months.
Okay. And then you can make any kind of training or
yeah, if you think about it, everything's going to be running parallel. So like once we get the blood work, like we'll set something in motion and then we can change or iterate based on the blood work and then ultimately get to the next blood panel and then say, well, did it work or not? So it holds us accountable as well.
Yep. And just to be clear, this is not like eat right for your blood type. Like
No. And if you want to get like super nitpicky, we can even match up fat burn, carb burn with your body fat percentage, your muscle mass percentage, so that the grams of carbs and the grams of fat you eat every day match for whatever your goal is, whether it's muscle building, weight loss, hypertrophy training, strength training, whatever it is. And I mean, you can get into the minutia of that with the data sets we have.
Like obviously we've functioned for a long time without blood work. So like if we were just using our typical analysis, let's use it as the analogy that's in a magnifying glass. With the blood panels, it's a microscope. So our precision and accuracy is going to be greatly improved and the feedback mechanisms improve as well.
Welcome back to the To Be Fit podcast. I'm your host, Brian Bott. Today, I am joined by Dr. Marko Lujic and Mike Ranfone of RTS Health. They are forging a new model that I will let them introduce you to, putting together medical and physical with fitness together. So I'm excited to talk to them. The coolest thing is that Marko is my doctor and Mike's my coach. So I've been looking forward to having you guys on for a while. So welcome.
Thanks for having us, man.
Awesome to be here.
So why don't you give us we started to talk about it off camera, but give me a little bit of the origin story. How'd this thing come together?
Where do you want to begin?
Yeah, so I mean, it was like Hamden Hall, 5th grade.
34 years ago, 35?
You know, and I walked into a school classroom that I had been part of for my whole life. I started there in pre-K in 5th grade. In came a gentleman from Branford, Connecticut, and then we kind of hit it off right away. Our desks were together.
Yeah, that's right. We got in trouble together.
Joking about the same stuff. You know, we kind of agreed on a lot of things, disagreed on the same things. And then the friendship just kept rolling. And then as of high school, college, we've always kept very close ties. We played different sports and we had different groups of friends here and there, but we always maintained some foundational relationship. And then it's just, since then, just grown and grown and grown.
And then kind of like where the converging ideas of working together came from when about 6 years ago, Marko came into the facility and had one of probably the best transformations physically, mentally, emotionally, professionally that I've ever seen. And that really was the catalyst. I believe at that moment was like, how do we start doing stuff together?
Yeah.
From a professional standpoint. But it was a long time in the works. Like we really had to give it a lot of thought and make sure that everything was above board in terms of the legalities, the finances, to have a working model that served our end user, but also made sure that it provided an opportunity for both of us to grow and develop into. So
and part of why it really gave me a lot of encouragement to start wanting to do this was, how many times in life are you faced with a problem someone presents to you about something you're doing, but they don't have the solution, right? They're just like, Brian, stop sneezing. And you're like, well, how do I do that, right? And the medical world is full of that. Like you go to doctors and you go to the hospitals and they're always telling you problems when they occur. And there's a lot of actionable items that they don't give you the answer to. So we just tried to put it together and figure out what are the answers to these questions in terms of healthcare, not sick care, but in terms of preventative care that we can answer for these people so that when they do want to avoid that interventional kind of medical type situation, we can keep them out of the hospitals and healthier.
So let's use that as a jump off point. Like what are you guys clarifying the difference between healthcare and sick care?
For my definition, I think healthcare is when you're improving somebody's health when they're already reasonably healthy relative to the standard we have. So if you fall within those normal limits or you fall within the average of your demographic, that's pretty good. But if we can make sure that that average goes up and up and up, and we keep everybody on board so that you do not get sick, that's healthcare to me. And then the definition of sick care is we've gotten to the point where an intervention has to happen that is not a natural occurring thing. So like I need to go put a piece of metal in your body, or I need to cut you with a knife and rearrange your organs, or I need to cut you with a knife and take an organ out that has failed, right? When you break it down to that, it's not as appealing as we run the cleanest cancer hospital in the country. Like that sounds appealing, but if I said to you, they're going to hit you with a knife, open you up and cut everything out, that's a little different. And that's sick care. You're already in a place where you need the last resort.
And now from a fitness standpoint, where do you look at that, Mike?
Well, I kind of use Charlie's paradigm of training equals rehab. And we've been influenced by him for decades at this point. But he really talked about like in the beginning, there was a dichotomy. There was training and there was rehab. And he was like, no, that doesn't make any sense. It operates on the same continuum. So if we just look farther down the road of that continuum, we can get into like true medical models and see that fitness should be part of that and probably was always a part of it. It's just contemporary lifestyle has like removed us from actually utilizing that in an appropriate way. And now we have to kind of subsidize some of those pieces back in. But the way that I look at it is like almost all the major afflictions that we're facing as a society right now can be tracked back to nutrition, physical fitness, lifestyle, and habits that have just eroded and actually required the medical interventions earlier on in different demographics. So I see fitness being a frontline aspect to healthcare. Therefore, I consider trainers, nutritionists, coaches as frontline healthcare workers. And that's really something that we try to have deliberately executed in the model, and why we didn't want, here's RTS health inside RTS. It's the same. It's just like, what part of the continuum do we have to leverage or utilize right now to give you your best ROI on your health span?
Yeah, and that's why it was very interesting and exciting to me, because I know for me, when we have clients come in, like, look, sometimes it's pretty obvious, right? If someone comes in and is like, I need to lose 50 pounds, like, right, I can help you, right? Like, period, right? We can do that with training and nutrition. But sometimes you get people who are, they might be a healthy, quote unquote, weight, but there's so much other shit that we're affecting with improving their nutrition and their training and their cardiovascular that I have no access to showing you. Yeah. Right. Like, unless we do some sort of blood work. Right. So like, what was the jump off point for you, Marko? Cause like you were a surgeon previously. I don't know how you want to label it, but like, and so what was the jump off point? Like, I want to move out of that and move into, this kind of
so
approach.
The first thought started when I went through that transformation, right? So I was typical, just finished residency, started making a paycheck, eating, having a couple of drinks on the weekends. Then it was like, oh, I should reward myself with more drinks and more food. And I don't need to work out. I spent my whole life working out. I played college sports, so I'm not going to hurt my body anymore going in the gym. I already did that. Well, then I realized after I went through that period of transformation, like, the biggest and most profound impact had nothing to do with a doctor, right? It was because I went to a gym where Mike took control of my health actually and was like, hey, you got to do these certain things. Now, I asked for it. I was ready to do it. I was bought in at that point in time. If we had done it maybe a year earlier, I probably wouldn't have stuck with it. And it kind of clicked. And I was like, whoa. This is the healthiest I've been. I've gone to physicals. I've had surgeries, orthopedic repairs of things where you're just never back to the same. And now I went in for a quote unquote healthcare treatment to a facility that didn't have a doctor. And I left 180'd and healthy as could be. So the humility, it took me a long time to admit that, right? Because in the doctor world, you never want to tell anybody that anybody but a doctor helped you get healthy, right? That's ridiculous. The trainers don't know anything, right? But I came to that conclusion. I said, then we started talking more, and I was like, there's no reason we shouldn't do that. And then I remember a very specific moment at the hospital, and I was in the locker room, and I'm changing, and our premier spine surgeon at the time was in there as well. He's 6 foot, maybe 5'10", 340 pounds, sweats, kind of a gross human, and he couldn't put his pants on without leaning against the locker, holding his scrubs with one hand, like wiggling his leg in. I won't use names, but so it literally hit me so hard at that time. I was like, that I can never end up like that. And like there's a continuum between training and rehab, it should all be the same. And I'm kind of in that gray zone. Like I'm getting healthy. I feel way healthier, but am I really doing it to the best of my ability? And I think being in that environment, I realized around people like that, I am not going to become the best version of myself. I might become the best financial version because that guy is going to know how to make money doing operations and teach you how to navigate the sick care world. But am I going to become a better person for that? And I was like, I'm not sold, but I am sold that if I surround myself with people that want to be healthy, want to promote health, and are not needing assistance from a wall to put their pants on at 50, then I'm in the right place. And that's what really solidified it for me.
So I guess to take a step back, what's the big problem that RTS Health is solving? Like, why isn't the traditional medical model right now of going to see your doctor, whatever, once a year or twice a year, maybe, right? And keeping up with your own health and fitness, like, why isn't that enough? And why the change or why the integration?
There's two fundamental reasons why I think what is currently available does not help people really promote health is that everything operates in the rears. Like typically you only go to the doctor, if you are, you have a yearly exam, you're going to your PCP, or something's wrong already. And sometimes you don't know if something's wrong until you have that yearly review with your doctor who's just telling you what has happened, not what's going to happen. So there's very little predictive value in what current medical models offer. And that's because the insurance companies and the whole infrastructure is set up where we'll operate from the rears. Where and I think you posed this question is like, is it preventative? Is it proactive? Well, I would definitely bias towards a proactive stance where we're trying to check certain markers of your physiology, your biology, your neurology, so that we can get in front of things. All right. So even if you present as a younger, lean, fit person, your blood work might tell a totally different story. And the blood work might be based on what he's looking for as identifying quality or features of your quality of life in the future, as opposed to what your PCP might say, oh, you're young, you're healthy, you look great, you check the box because you're being measured against what's normal, right? So there's just a different standard of care. And Marko can speak on this better, is that we're comparing you to you and where you're going, not against this subset of data that doesn't even represent health anyways.
Right. And I think it matters because for some reason in the health world, we don't view it the same as like academics or sports. We view it as like, well, if you go to the doctor and pay some money into a system, you're going to get that reward. Well, in academics, you can pay to go to Yale or Harvard, and if you just sit in class and don't listen, you'll get nothing out of it. In any other world where you can pay for something, you can potentially get it or not, depending how involved you are. My problem and where I wanted to fill the gap was there are people that are healthy and really want to become better. And the system that's in place right now offers zero from the medical end, because all we do is wait for things to break. So we're not good at helping out up front. So the gap in healthy people's lives is really the biggest niche. But then if you are feeling like you're not in that average health and you want to get there, that's just as valuable too. But the offering really is for the people that want more out of a system that they're paying into and getting nothing in return.
Yeah, because I think the main overlying theme there is like there's a difference between, quote unquote normal and optimal, right? So because a lot of times, like I know my experience from going to a doctor before, it's like you get your blood work back. Me, who's I would say more educated than the average person, but I'm certainly not a doctor. I look at half of these things and I don't know, I know the basic stuff. Like if I'm looking at like my glucose levels or things like that, I can have an idea. But some of these other things, I'm like, the range is 2 to 1,000, right? And if you're 3, you're normal, right? It's like, but if last year I was 500 and that was normal, but this year I'm 300 and I'm still normal, and then it's 100, like there's a trend there, right? I'm going in I'm trending in the wrong direction, even though they all still fall within that normal range. And I think So for me, I know that was even with, I don't mind sharing my own stuff. Like I would never have looked at my thyroid levels and think like, oh, this is something that I can improve, because it was on the lower spectrum or whatever. And we could talk about this as a separate issue, but like you guys both know, like I'm just a generally a apprehensive person when it comes to medicine, right? Because of my experience with doctors and family and stuff. It's like, for me to like take, like I don't even take Advil, right? Because I'm like, I don't want to like, but I know for me, even taking that amount and seeing the difference in how I feel just from something that would have normally been quote unquote normal has been tremendous, right? Yeah. So I can't imagine for people who have levels that are,
completely,
not even just suboptimal, but subnormal.
And that's the crazy thing.
On a daily basis.
That's what people are normalizing.
Right.
They're normalizing feeling like shit. Because what are they comparing it to? Especially when if they feel like kind of not great, but they go to their doctor and their doctor's like, well, everything's normal. So now they're like, okay, well then this is what it is.
That was kind of like when you're feeling a certain way, like you almost like, I was joking with Marko about my blood work. Like, so if you're battling something, right, you're like, well, I hope I get these numbers back and something's wrong, because like, at least then I can fix it. Right. Like if I feel like shit and then this guy's telling me everything's fine, I guess I need a psychologist. I need to evaluate my view on life.
And that's really the biggest issue. I mean, I don't want to start getting too sidetracked, but with women's healthcare that we have done over time, like if you take that abused spouse syndrome type thing, like if you're continuously getting positive reinforcement for what is bad activity, right, you're gonna keep doing it. So these people go to the doctor, they're, like Mike said, they're told, oh, well, that's normal. So they feel like shit. They were looking for the answer. Now they're told everything's normal. So they just think, well, that's how I'm supposed to be, right? Which is why, back to my initial reason to get into this field, like I was surrounded by, whether they liked it or not, greed driven off illness, right? So the more spine operations that monster did, the more he ate and went to Vegas and could gamble, right? Like it kept feeding his bad habits by operating on people potentially with back surgery needs, but maybe there's some gray area in there too, right? So all of that kind of associating a feeling with normal became really not congruent in my brain. And I was like, I shouldn't feel normal in the locker room with somebody like that, or I shouldn't feel normal being excited to remove somebody's gallbladder because I'm going to make some money, right? Like that's a bad thing to do. So that reward system and that normalizing the abnormal is what we've been doing in the medical system forever. And people don't even know that this exists, because I get people come in like you that are very questioning of it, which you should be, because it is something so new. But they don't even realize they have the potential to feel better. And that's what really drives me more than anything.
So take me through the model, right? If I come in, I'm not feeling my best and I'm going to go through the RTS system. What does that look like, from an intake standpoint?
Our ideal client is as follows.
Yeah. I mean, so we do have a single point of entry. So if someone came in, let's just say a cold inquiry comes in, they would typically meet with me, and then I would help place them in the right position to get going. Now, ideally, they would start both service lines running parallel. So they would come in for maybe a physical eval. We'd then get them blood work. We'd go through a DEXA and some of the other diagnostics. And then Marko and I would come up with the treatment plan. And we always kind of annualize this so that we can track back to what we have to do right now. So if we take a worst case scenario where someone's really underfit, overweight, has some legitimate medical concerns, what could we do in a year so that we're not like squeezing everything in? And then we reverse engineer that and create like a hierarchy of needs. All right, so what does month one look like? Right. So this is what their training, this is what their nutrition, this is what their, medical support should look like. Where do we check in again? And most of this is very much choreographed, but we try to make sure that like if I'm pulling a lever, it is on the other side of the lever that he's trying to pull. So we get this like exponential result in a very quick manner.
So someone like myself who's in the fitness field might have a little bit more adherence to change or might not need as many. But if you're taking someone who's like, look, guys, I've never worked out before in my life. I had a medical scare. Now I'm ready to do it. Right. There's the behavioral component of it as well. Like we can have all the information, but like how do we stepwise get people to take that that leap, right? Because if it's like, hey, I came into the office, now all of a sudden, like I know a lot of people's fear or reservation is like, they're going to tell me I need to take all these supplements, and now I'm going to need to work out 6 days a week, and it just becomes like information overload, and they can't do it. So how do you guys like kind of coordinate together on what that looks like in terms of like a treatment plan for somebody?
We definitely take a look at what are the non-negotiables. So if let's just use a classic example of someone that's overweight and underfit. Well, then we have to kind of figure out what we can do. And that might be a more nutrition strategy rather than the fitness strategy. That might just be walking and making sure that they're not drinking soda. Let's just say that those are the low-hanging fruit.
Regular soda, diet's okay.
Yeah, diet soda is great. And then on his side, he might be saying, well, we're going to have to start a peptide protocol or a hormone protocol or something else. But the big piece of that is like we have the objective data that can help guide them. Right. So it's not like we're guessing at what should be done. We're using that as a back-end confirmation to solidify the habit formation that needs that to take place.
For instance, like we have a client at the gym who weight loss was the primary lever we had to do. So we used a little GLP-1, which we can talk about down the road. We got him on the weight loss journey. Less focus on anything except weight loss. We got his weight down. We transitioned him off that. Then with good metabolic conditioning, because now he's on the GLP-1, he's in that transition, he's built that lifestyle change in his head. We got him off it, started him on supplementation, his thyroid, his vitamins, some enclomiphene, and all of a sudden, this person that was 300 pounds and 30+% body fat lost, 15% body fat, down to about 18, 20% body fat now, gained a bunch of muscle, is off the GLP-1, knows how to eat, loves lifting, and now their entire life has changed, right? So unless you do that in a coordinated effort, what's going to happen is the GLP-1 prescriber is a single individual. Your trainer is a different individual. Your primary care is a third individual. They don't talk. You stay on the GLP-1. You don't want to tell anybody because just that person doesn't know that this person really wants you off it. And the next thing you know, you're back to square one. You're just a smaller version of higher body fat percentage self. So it's that sort of coordinated care. And I think the reason it triggered that train of thought is Mike said, annualize. And it's a good goal to say, okay, 6 months to a year, we need to accomplish this. Then we can transition to the goal number 2. But while we're taking care of the primary, we don't want to put anything for goal number 2 at risk. And the only way you can do that is coordination between the medical and the physical end of it.
Yep. And then that's where like you try to describe to people like when they ask like, well, can we do all this at the same time? And it's like, well, how do you define time? Over a year, yeah, we can do it all at the same time, but it's in these blocks. And I think I don't want to go too far down the tangent with the GLP-1s, but especially with fitness, it has to coordinate because you see people that are trying to like obviously the path and the process that you just described is much different than like, hey, this clinic down here will just give it to me and I just figure I'll just take it and I'll still go to my 4 times a week HIIT classes and now I don't understand why I can't feel worse.
I feel like shit.
Yeah, because those things just don't coordinate together. So I want to get into some like practical examples, like if people like because they go to their doctor, they get their blood work and what are like, from your guys' components, the 4 or 5 things that on their own, if they're like, I just want to look at this and get a ballpark, like, understanding of are these things, what are the ones that are the most important for them to kind of keep their eyes on from an overall health and fitness standpoint?
I mean, if I were to say which items you should 100% look at and you can get the most information out of them, fasting glucose, your fasting insulin, a hemoglobin A1C, a cortisol, an IGF-1, and then in your lipid profile, an ApoA and ApoB. And between those 7 items, if you were to give me a client and I needed to treat them as aggressively as possible, those pieces of data would give me the best shot at doing it overall. But those are the most important markers for metabolic health in my mind.
Yeah, and I don't want to make it turn into like a quiz show off the top of your head, but like I know when I did, so for people listening, like after I had my initial blood work done, I think you and I were on the phone for or through Zoom for like over an hour.
Yep.
Right. So this isn't like you get your sheet and here you go. Like, and I really appreciated, even though I have a decent amount of knowledge, but like some of the analogies that you gave of like, hey, this is what this is doing. This is, so, let's run through those 5 or 6, as long as much time as you want to take, really.
Yeah.
Like, why are those important, and what are the kind of the drivers that they need to look at for that?
Yeah. So the biggest killer is vascular disease. And the way you combat that is by decreasing the insult to your vascular system. The way you do that is by building muscle, being metabolically active, and then maintaining levels of certain chemicals in your blood that will give you the least amount of wear and tear that your body's able to keep up with. And that's all it is. It's a risk-benefit ratio that you just need to keep neutral. So when I look at these things, the fasting glucose really gives you is this person's blood sugar completely out of whack? Because if their fasting glucose is above 110, 120, they're already, the rest is going to be downhill. So that's one insight. So that person, say it's normal, is reasonable. Okay, now we're going to go to the next indicator of glucose. Now, glucose is important because it's a carbohydrate marker. That's all of your energy sources. But in excess, it'll decrease your oxygen carrying capacity and irritate your blood vessels, right? So it has a couple different irritant values to it. So then if you look at the glucose, you then look at the fasting insulin. Now, if the fasting glucose is normal and the fasting insulin is like 20, that's a mismatch. But if the fasting glucose is normal and the fasting insulin is 2 to 5, now that's a nice match. So you're like, all right, this person's starting to proceed. That fasting insulin is going to tell you a couple of things. One, is the pancreas overworking or getting tired? Because it could be really, really high or really, really low. And then it'll tell you your insulin sensitivity, potentially, right? Because if your fasting glucose is normal and your fasting insulin is really high, that means your pancreas is screaming at your body to use insulin. Now to use sugar. Now your body might be using it, right? But it's getting used because it's getting yelled at. You don't really want to have to yell at your body to use sugar. So now that mismatch will lead us to, there's something metabolically off. Now that same person, you then check a hemoglobin A1C, which is a measure of changes in your hemoglobin due to exposure to sugars or carbohydrates over time. If it's higher than 5.6, up to about 6.3 in the United States, people say you're pre-diabetic. You're diabetic in my book unless you start changing something, because from 5.6 up, you are now risk benefit heavy on the risk. You've now changed that normal wear and tear into excess. Now you can still have somebody, normal fasting glucose, normal fasting insulin, normal hemoglobin A1C, but say on the upper level. So say their hemoglobin A1C is 5.5. Their fasting insulin's 7. Their fasting glucose is 90. So they're not a diabetic in anybody else's office. Now I go look at something called 1,5-anhydroglucitol. This is a very acute changing, but measure of glucose intake. And I see that number and it's either really low or really high. Now I know those first 3 pieces of evidence are what they're telling me from dietary lifestyle or not. Because if it's really, really high, they're not eating enough carbs. If it's really, really low, they're over consuming. And now I can tell you your whole carbohydrate metabolic profile right away, right? So those 4 things, energy and vascular injury, we can take care of with that 4 pieces of data. Then we get into the next biggest offending agent in your body, which is cholesterol. Now you need cholesterol. It is good for you. I'm going to repeat, I am not saying it's bad. You just need it in the right amount, right? Like oil in your car, a quart or 2 is really good in the tank at a quart or 2. But if you took 80 gallons of oil and poured it all over your car and the tank was still full, you'd have not a good situation. And that's the same with the human body. You need that cholesterol to run. You just don't need it in excess. So the total cholesterol I got rid of on that panel, you asked me what would be the most important, because I don't really care about total cholesterol. I want to know the trends over time. And those trends over time are told to me by something called ApoA and ApoB. Those are cholesterol carriers. What do they carry? Well, they carry the LDL and HDL type of cholesterol. ApoA carries HDL, ApoB carries LDL. That ratio will indicate to me if you are eating dietary fats in the right amount relative to each other, in the right amount in total quantity, in the right amount under eating, whatever we need to know. And it is a very, very good predictor of vascular disease. And then added to that, now you have your carbohydrate and your fat metabolism, right? And essentially between those two, for rudimentary baseline, I can really tell you, is this person going that way or that way? That's the founding basis, because it's energy production and vascular damage. And those are the items I would say are the most clear-cut, most important 5 things on your blood test.
And I think a couple of things there just to kind of touch on is that, like, you talked about, like, hey, these levels in your book, they're diabetic, right?
Yep.
And I obviously I'm not a doctor, but when I'm going over those things with my clients, I'm like, look, 99.9 degree water, I still don't want to put my hand in it.
Yeah.
Right. Like,
that's what I mean.
Shit's gonna hurt.
Yeah.
It's not boiling, but like it's going to.
Yep.
Right. And so I still wouldn't want to use that. Right. And then pointing out, like, from how this integrates with what your approach, Mike, is that I'm assuming it would make your job a lot easier, because let's just use fat intake as an example, right? With all the information and shit that gets popularized now, it's like most of those diets lean towards being a lot higher in fat, specifically saturated fat. Doesn't mean it's bad, right? But I would imagine years ago, before having this integration, if someone came in your office and you were like, I think we need to eat more carbs, they'd be like, this guy doesn't know what the hell he's talking about.
Right.
Like, But now I have data. I can show you why I'm saying that. And then, you correct me if I'm wrong, because I'm not in that model, but how is that making your job easier as their nutrition coach into some of the interventions that you might want to make?
Well, yeah. Subsequent to getting the blood work done, there's also a test called an RMR, the resting metabolic rate, which also kind of gives us a snapshot of like what their caloric burn is, their basal metabolic rate is, as well as does their metabolism prefer fat or carbohydrate. So now we have a pretty good objective set of data so that we can bring that to the individual. Like, I think that's really important, because a lot of times, like, hey, I like keto, so you're going to do keto. Hey, I like this style diet, like, you're going to do it. So a lot of times their prior experience are based on the individual practitioner's preferences, personal preferences, not professional opinions or ideas. The other real key component here is actually having a doctor talk about this stuff, and then we back it up, right? Which is pretty cool. One of the things that I think is worth noting is all the metabolic stuff that he's talking about is 100% treatable by actions and habits, right? Instead of saying, hey, you're trending towards diabetes, here's a medication. It's like, you're trending towards diabetes, why don't you lift some weights?
Yeah.
So like his stance is purely 100% to back up the habit formation that we want to enforce, right? Or that we want to execute on. So when we're talking about metabolic panel, which is probably if you're a trainer, coach listening to this, know your metabolic panels, because it is 100% in your wheelhouse to influence that on the daily.
Yeah.
Right. So resistance training, cardiovascular type zone training, and nutrition, all those things can be impacted. And then you, in 3 months, when he gets another blood panel, you can get confirmed or confirmation that it is working. So I think it just helps me really figure out, well, how much muscle, how much resistance training. So it gets into the logistics of it. Because let's be honest, like most people who are in this case or situation, they need to lift weights, they need to up some cardio, and they need to eat better. But it gives you the devil's in the details, and it gives you the exact amount of what you should be doing for that habit formation to stick, and then give you some guarantee that it will work in the long run.
It's kind of like if you took the world's best spine surgeon, right, and you allowed that person, he or she, to go work with physical therapists with babies from the day they're born till they're adults to avoid spine injury, I'm sure your outcomes would be better, right, with spine injuries down the road. So this kind of allows us that interventional aspect where we can get into them at ground floor with exercise nutrition, and then we can get into it with medicine. But I think the big advantage I have is I've seen inside people's bodies. So like when I tell you have visceral fat, I know what that looks like. It's in my brain. I know what's going on the inside. I know how that functions. I know what it irritates. So it's a very different perspective. The second thing is in the hospital, every treatment is based on something that's not hands-on for the doctor, right? So it's, here, take this pill, go take it. How often do they say that? Go take this medicine. So leave, get out of my face. Take this medicine, and when I see it back, let's see what happened. That's not a good approach. I say to people, hey, here's the stuff you're gonna be taking. It's gonna improve you, and then you know what? I see them, a lot of people, almost every day in the gym, and then we have lots of touch points. But the biggest is the fact that from an exercise nutrition end of it, we can stay on them. So we treat diabetes, we treat metabolic syndromes. We don't just cover up their symptoms. And that's the biggest effect for me that I appreciate the most.
And here's just a cool note. You know, I'm going to blow smoke up our ass, but like in a doctor scenario where he gives you a pill and says, all right, I'll see you in 3 months, 6 months, next year. And you literally don't see him until that next visit. His doctor's office is in the gym. So when he says, hey, I'm prescribing you training 3 times a week, nutrition, and you're going to do daily check-ins with your coach, guess what? The accountability piece, which really is the hub of all this, is there from start to finish, right? So like he can ask me if that client's coming in. I can ask one of the coaches. He can ask the PA, like, what do we know about how Johnny's doing?
Right.
You know what I mean? So it doesn't happen on these longer time horizons. It happens daily. It happens weekly. There's monthly cadences. There's communication at every piece of labor that's in place. And I just think that's a really interesting dynamic of the experience that ultimately produces these results.
Yeah, and there's a big difference when you show up and you see your doctor doing pull-ups and deadlifting and actually performing. Because I remember, I don't know when Charlie said it, but I remember he's like, I'm not really interested in your PT's rehab protocol if they can't do 5 chin-ups, right? Or if they can't run a mile and nothing crazy, like they don't have to do a 5-minute mile, but something.
Well, you walk the walk a little bit.
So, I think that's a huge piece of it, because there's so many times that I hear from clients or family members like, well, my blood pressure is good. And it's like, wow, yeah, because you're taking and it's not to knock the medication. It's like, they said it's perfect now. I'm like, all right, but like that's enabling all the other behaviors that got it to that point.
Right.
Like you can mask that one symptom, but now all the other symptoms that might have still been normal are now still going up because you're not treating that.
Well, imagine if a doctor walked in to a room and said to a patient, hey, your blood pressure's still going up. And they say, well, I take my medicine. You put me on 50 metoprolol or 100 metoprolol. And the doctor said to them, well, we're not going to go up on the dose. That's the highest dose available to us. That person then has to make the choice. Either I fix my blood pressure or I don't, right? But our accountability as physicians in a hospital to what you were just saying would be to increase the dose, reinforcing the person's bad behavior. Like if someone came in non-compliant with exercise, you can see it. Like you're weaker, you're less in shape, whatever. We see that as doctors in an office in a hospital. And what do? Oh, just here's more medicine. Sorry, this will help you, right? So it's like, it's just that backwards approach.
And we talk about root cause a lot, all right? Like, so whatever medical affliction or whatever he's identified from the medical side, you could give him a pill. You could talk about like the underlying mechanisms of physiology that's causing it and then try to get there. But really, everything then tracks back to the daily habits. So to your point, if you give them a pill, you're enabling them to continue to do the habits so like, what is the root cause? For the most part, outside of, medical outliers, there's something that they can actually do that is in their control and that is based on decisions, which can't happen. Those good decisions can't happen without good information. So I think that's why this works really well together, because we've given you all the objective data, we've given you the know-how, we've given you what to do, and then hopefully we've given you the support system of the people, the community, the knowledge, the skills of the whole facility and the staff, so that those things are now reasonably done.
Yeah, because I think a lot of times people, they get the information from their doctor, let's just say, and it's like, well, he just told me I need to lose some weight.
Yeah.
It's like, how?
Yeah.
Like by doing what? Like,
right.
And now again, I do want to cover some of the GLP-1 stuff, because I'm sure there's some people that are listening that are like, wait a minute, this guy's prescribing like this stuff. It's right. People have misconceptions, like they think it's cheating or whatever, and it's like,
whatever
at what?
Means.
Like, at what?
Just like TRT is cheating.
Yeah,
right?
And it's like, so what is your approach on something like that? Like, because I know there would be a lot of people that, again, I tend to disagree, but they would look at that and be like, oh, that's ridiculous. But, you mentioned, hey, and then we got him off of that. So, what is that approach? Because I'm more interested in like Mike was talking about, and some of the behavioral stuff. Sometimes you need wins, right?
Yeah.
Because if you can't chalk up an early win,
Yep.
the person's out, and then they're not like, this isn't working, and they're not ready to make some of the other behavioral changes for 1,000 reasons.
Right.
So what does that look like?
So for me, the GLP-1 is it's a really good wheelchair to help you get to the place until you can stand up and really walk, right? And the thing is, you don't want to just leave that person on the ground, right? So that person can't use their legs, they're on the ground. At least put them in that wheelchair so you can start pushing them. And then the minute they realize, whoa, I can move, and then you can rebuild their confidence, their strength in themselves, their habits, then they can stand up and walk. That's the analogy, right? The GLP-1 is the wheelchair. So that person who just can't get off the ground, like at the end of the day is like, I'm still so depressed, nothing works, I'm still the same weight today, I'm gonna eat. It'll break that cycle. The same way opioids were invented to break the cycle of pain after surgery. So you can then allow your body to relax and then wean off the opioid to become back to normal. Well, that GLP-1 should be used the same. It's that wheelchair, it's that crutch. And then once that person has now been given that little bit of push, they start to see the weight fall off. They're not as hungry. Their mental capacity to not eat all the time is getting better and better. They'll start to realize the benefits of feeling that way. So you do that over a course of time. And then when you get to somewhat near their target weight, there should be an offboarding situation, which we do all the time, successfully. You do not just instantly gain back all the weight. And the way you do it successfully is at the end of that adventure, you're reintroducing all this food, but you're reintroducing really strenuous activity that's going to stress those muscles out and use all that food. And now you've transitioned that person. So the GLP-1 to me, it's like Suboxone or methadone. It's something to help you stop wanting that drug of choice, which for those people is food, so that you can allow your body to realize, like, even without that amount of food, I'm living and I feel better. So then you start associating less eating with feeling better. And that's how you build good habits. So to me, that's all it is. It's a crutch. Here and there, it'll help. It'll get people through difficult areas, through plateaus. It should just never be immediately thought of as a lifelong journey, right? It should be only available and only really desirable for that interim push. That's my take on it.
And from a fitness standpoint, I'm sure, Mike, like how does that influence what you're going to be doing with that person from a nutrition intake? Because I know, like, for us, it's hard because a lot of, like you said, people don't want to offer it up. And you're like, well, I haven't seen you in 6 months and you lost 40 pounds.
Yeah,
like,
yeah.
Are we gonna talk about this?
Yeah,
or like,
yeah.
because like I think I can help, but like we gotta have it all the cards on the
Yeah.
table. So again, the model that you guys are approaching is that it eliminates all that, right? It's all, I would assume, at least for the most part, out in the open, right?
Yeah.
Like, hey, I know what you're taking, what you're doing, so we're gonna focus on. We really have to prioritize, trying to lift heavy, like and prioritizing that. So what's that look like from a fitness standpoint for people that are at that dose?
Yeah, I just want to take a step back, though. I think it's important to recognize, because you brought this up, of getting wins and getting wins fast. And I think one of the best things we can do, whether they're on a GLP-1 or TRT or whatever else, is to lower the friction that person faces when they're not in the gym, right? So everything that lives outside the gym, how can we make it easier for them to get through and navigate so that they don't have to manage this extra stress and this extra overwhelm trying to figure it out, right? And I think the GLP-1 does a great job of quelling that noise that surrounds food, because that's probably one of the biggest obstacles for them. So if we can just get that out of the way and be like, all right, now you don't have to worry about it just yet, and we can start to build up the habits, because let's just say that this person's never trained or hasn't trained in 20 years. They don't have the habit formation to even know when to go to the gym, what to do at the gym. I don't even have sneakers, Mike. So there's millions of different things that they have to face from an obstacle standpoint that we then have to address. And if we just take that big one off, then we can get to those things. From the actual specifics of training, it is obviously very much customized to the individual, but there are certain programming considerations. Like, if they're eating a way less food, do they have the energy what kind of energy do we have to expend on the activities that we want them to do that gives them the best ROI. So that might be like, hey, you don't have to go to the gym 5 days a week, but you got to get 8,000 steps because you were at 2 last week, per day, and you're going to come to the gym twice, and like we'll really be able to manage high effort but maximal rest so that we're not creating more fatigue, which, as we know, any type of fatigue settles in, choices are worse, motivation gets worse, discouragement sets in.
Your steps go back down.
100%. So we have to be very cognizant of because we are implementing a very powerful pharmaceutical. What are the downstream effects of that, and how do we then manage that? And that's why we collect data. And you know this, like, what are your steps? What's your sleep? What's your hydration? What's your calories? So on and so forth. So,
and unfortunately, in our world, and this is a little more philosophical, but in medical world, it's very true. We never really let anybody hit rock bottom. Like when people are like, I'm at rock bottom, you're not really, right? Like the rock bottom is death. That's rock bottom. Like I hate when people are like, oh, I hit rock bottom, I'm back on top. You never died. Yeah. Death is rock bottom. Okay. So
Can we cut in that? But did you die?
But did you die? Wait, what was my shirt?
Did we sink?
Did we sink?
I got him for his birthday.
It's awesome. But like that's rock bottom. Okay. So anything above that, we got a shot. Mm-hmm. And we have plenty of people too that don't need the GLP-1, right? Like I have plenty of clients that are like, I'm just ready to do this. And you can like feel it. It's a different intensity. So those people might be more motivated to just go buy the sneakers and end up at the gym, but now need the guidance in the gym. So there's all levels of spectrum. But the biggest advantage that GLP-1s give is that victory of not wanting to eat. Because that's an uncontrollable out-of-body experience for a lot of people, right? We've all had it. We've all opened the jar of peanut butter. We've all looked at the piece of bread and we've said to ourselves, I'm not eating it. And you leave the room and what happens 5 minutes later? You're just like, nope. Fuck it. I'm eating the whole thing, right? And you gorge. Now, most of us do that a couple times here and there. But for the average person fighting obesity, that urge is there all the time. And like schizophrenics, like bipolar, like people that hear voices, it's almost an uncontrollable out-of-body experience. Like, why am I doing this? Why can't I control myself? So imagine, just like you give somebody who hears voices in their head a pill that helps quell that voice, you give somebody the opportunity to be like, oh,
silence.
I'm relaxed. Like, I'm not fighting myself tonight in the kitchen over the marshmallows or the extra bite of cheeseburger, right? And that alone, removing that second opinion from their day-to-day decisions that they don't have control over is awesome. And that's what I've found. Instead of people saying this like food noise goes away, no, your obese second alter ego disappears. You kill it, right? It doesn't allow yourself to speak to yourself about food anymore. And that to me is the biggest advantage. So once you kind of do that for a long enough period of time, and then the person that never went to the gym that didn't have sneakers buys the sneakers. Now they can wake up without the noise and put the sneakers on and actually drive to the gym. Even if that alone was accomplished, that's a victory, right? So now you're building wins, wins, wins over the course of whatever amount of time we want to say, even though in my mind it's a lifelong health journey, you can build better habits. And I think that's the best version of use for that specific type of medicine.
Yeah, I mean, the actions and the behaviors and all the things that you still need to do, it just makes the environment in which you're trying to do them a little bit easier.
That's exactly
right. So like, that's why I don't like, I would much rather someone like, at that point it's a life-saving activity, right? Like if you don't do this, like, you are not going to change that behavior because, some of the psychological and behavioral things that people have now linked to eating to deal with are much harder to change than any of us are going to give credit towards. And then if it doesn't work, that feedback loop of I tried, it didn't work. I tried, it didn't work continues. And if the intervention is a drug like that can help break that cycle, then go for it. Yeah,
and think about the environment. Like when you drive down the road, like on our ride here, there's John Bon Jovi Plaza. It's like food. So even in the middle of a huge run, 2-3 hour drive, you have the opportunity to be distracted by like immediate
Food.
access
Am
to
I
like
hungry? No, but I should get
huge
something.
amounts of food, right?
Yeah.
So the environment is so tough to deal with around us, and I think it helps make that a more tolerable situation.
The other funny thing about, I don't know if it's just contemporary culture, but you can be shamed for doing anything.
Yeah.
So you can be fat shamed, and then you're like, you know what, I'm going to get help and I'm going to get on a GLP-1. And then it's all of a sudden cheating. So what am I? You're going to shame me for taking the drug, or should I just be fat?
Right.
Am I cheating because I'm on TRT as a grown ass man who doesn't get tested by I think it's like the psychological safety that is also provided by a doctor that gets it, a staff that gets it, and also like the community, the end users are understanding of where you are.
Yeah.
They all believe that everyone who comes into our facility operates from some deficit that they're just trying to improve on. Yeah. So it's not like, why are you here? What's wrong with you? It's like, oh, you're trying to get better and you're using the appropriate means and resources to do that.
Yeah.
And I think there's some comfort and security in that as well.
Mm-hmm. So let's jump into TRT as a topic, because I know it's definitely something a lot of people, it's been around for a long time, but now it's gaining more and more. I don't want to say popularity, but maybe attention.
Yeah.
I grew up in a sport around powerlifting, so I grew up around people who took a shit ton of drugs. And I don't care. Like in powerlifting, I've talked about it in previous podcasts. It was always super simple. Like if you competed in the pro division, there was no tests. If you competed in the amateur division, you got tested.
Yeah,
so who cares?
Yeah.
Like you do whatever you want. Right. So I know me as a teenager, early 20s, seeing it, like that was my first impression of like, oh, this is what it looks like taking drugs.
Yeah.
And I was like, that don't look good. Right. But so that's where a lot of my own misconceptions and stuff around on that kind of reform, because I'm like, this person can't even breathe. I'm like, how is this healthy?
Can I bust in on one quick thing? Mm-hmm. So like, it's funny because in the bodybuilding industry, everyone poo-poos them because they're so big and muscular. They did all these drugs. It's so dangerous. They might die. Yet people watch NASCAR every day and guys drive around a track and kill themselves constantly. So like the job might require a little more risk.
Sure.
So if you're risk averse, don't go into bodybuilding.
Yep.
Sorry.
No, absolutely. And that's why I always I always lifted in amateur, because I'd be like, it terrifies me.
Yeah.
Right. And it was never a judgmental thing. Everybody else I lifted with,
Sure.
So it was like, they were nice to me, so it was never that big of a deal. But I think that's a lot of people's, if I had to try to identify where do the misconceptions come from, is it's like, Dan John always talks about, like, if you tell people that you lift weights, like they assume bodybuilding, right? They assume body, like he was like, I'm an Olympic weightlifter. Like if I tell people I do that, they just go like, oh, so you get on stage and you flex. Cause like, that's like the vision that they have if you say weightlifting, right? So I think a lot of times when people hear that, they think like, oh, this person's on a ton of drugs or everything like that.
Yeah.
So, what are some of the misconceptions that are around TRT that, would be helpful for you guys to kind of clear up for people?
Yeah, there's a lot.
Yeah.
It is somehow been made faux pas, right? And it shouldn't be. The biggest thing I would say to people is, if you have a child, anybody listening, and it's a son, you would never consciously de-optimize or block their testosterone to make them healthier. Ever. Never. It's never, ever been done. So then why is testosterone labeled as this bad substance, right? Because the highest levels in your body are when you're in your 20s. 20-year-olds live a lot longer than 80-year-olds with really low levels of testosterone. So that doesn't even make sense, that data. The second piece is there were a couple studies put out, one of which had really low power. It was a very poor subset of individuals, some of which already had prostate cancer before the study, so their risk of recurrence was already really high. And they did a study with like 6 to 8 people, and they saw cancer in some testosterone users, right? Fine, there's cancer in men at a percentage. There's cancer in not, like, there's cancers out there. Can we label them on testosterone? There's no way, right? And then over time now, we've proven in urology data that testosterone does not cause cancer. And I think that's the biggest thing is the cancer. The second biggest is people are like, well, I don't want to become like the Hulk and get super bulky. And I can't help,
Yeah.
This is like a hot topic in this world. Like, to get bulky, people, It's a conscious, really
concerted
effort to do that. You will not just all of a sudden turn into a bulky bodybuilder. And then the third thing is, am I going to turn into the Hulk mentally? No, right? So the bodybuilding industry is what exposed anabolic use to the world. But the bodybuilding industry was abusers. So if I said to everyone in the world, like, here's your group of opioid abusers, if this was done like years and years ago, right? So say I showed them every heroin addict in the world. I was like, this is heroin. And then I actually said to them, opioids are heroin. Way less people would have taken it, right? But the fact of the matter is, for the right uses, it's really good in surgery, post-op, like in acute care for pain and situations that are traumatic. It's really, really good, right? So testosterone, when in the right amount, used in the right time, in the right person, with the right training, with the right monitoring, is an amazing substance. And you know it's amazing because it's in everybody's body. So the myths of turning mentally into the Hulk or physically or the cancer, it's just not true. And it's quite the opposite. I would guarantee, treated about 40 to 45 people, cured their diabetes with the use of testosterone. And it is not attributable to anything else. That is the root cause of what allowed them to build more muscle, to build their metabolic engine, and actually cure diabetes. I spent years in hospital medicine. I watched this many people get cured of diabetes. 0. I watched their blood sugars get fixed.
And 0 from testosterone.
And none from testosterone. But at the end of the day, the benefits greatly outweigh the risks. And the risks, if done the right way, really are 0.
And I think it just like any of the other stuff is like, right? Like people don't understand all the other stuff that competitive lifters are taking aside from just testosterone
or their lifestyle.
Yeah. Listen, the sport of powerlifting was not the most healthy.
No.
Right? Like we'd be training in the morning and guys would be just eating boxes of Vitamins, right? This is not like people weren't coming down, and having egg white omelets and fruit
because their only priority was output of power, right? Like they just needed to lift a lot, and that was the risk they took.
Well, it was also the misconception, and this usually happens at pretty much every high performance level. They equate health and performance. You know what I mean? So it's like, point. It's like, oh, that guy's the best running back in the world. He's got to be healthy. It's like, no, he's in pain every day that he walks around.
Yeah,
you know what I mean? Like, eat Skittles, right?
Like Ronnie Coleman, when he could squat 800 pounds for reps. Like, that's the healthiest guy on the planet, but really, no.
Yeah, terrible. A lot of it is like we try to draw these simple stories together. Like health is like having a 6-pack. Happiness is having $1 million in your bank account. It's not that easy. You got to look at everything that's peripheral to what you're looking at as well.
So what are some of the things that you do monitor on people's, like if they do make that decision, like, hey, I'm gonna start using TRT, are there things that you monitor?
Without a doubt. So I mean, in my practice, every 3 months we get panels of labs. We follow a PSA on every adult male every 3 months. On women, we follow their total and free testosterone levels and everything else. But the biggest interaction for the guys really so far that I've seen is that fasting glucose, their testosterone levels, and then some of their cholesterol. The only downside, which you might see in testosterone use, is a little bit of increase in blood pressure. And almost every time right now, my subset of data is not huge for my own personal anecdotal. So I've only had about 4 people have a little bit of a blood pressure raise. I dropped their testosterone by a little bit, down maybe 100 points total, 2 to 3 points free, and it went away. So I don't know the direct reason for that. I think it's vessel compliance more so than anything, or muscle building around those vessels so quickly that the vessel doesn't have time to react to the surrounding environment. But whatever it was fixable. And we went back up on the dose a few months later, and 2 of them, no issues with blood pressure. So really blood pressure is the only thing, which is a completely manageable side effect. I don't really call it a side effect as of now, that we can change. But that's pretty much it.
Because I know, can you just maybe give me a napkin math with the numbers of it, right? Because I know this is something that guys are becoming more and more cognizant about.
Yeah.
And they're usually just kind of focused on the wrong numbers, right?
Yep.
Like they, they're like, oh, I got this number from my doctor. He said it's good, right? But then you look at maybe their free numbers and they're not good.
Yeah.
Right? So like if someone's looking at their blood work, I know you broke it down for me of like, you definitely need to do this. You'd probably feel better if you did this. You could if you want, but it might not make that much of a difference.
Right. So the biggest things for a guy that I would look at are total testosterone, free testosterone, the percentage, and then the percentage doesn't match the numbers of total and free. I'll look at what's called SHBG, which is a protein your liver makes called steroid hormone binding globulin, which essentially is like a corrections officer for testosterone. It keeps them in jail so that it can't be used. Usually stimulated by estrogenergic type stimulation. So if you look at those numbers, the total to me doesn't actually really matter. It just lets me know that people are taking the right amount that I'm telling them, right? The free, I want around 25 to 30. So normal 18 and up, adult male, the normal range is between 2.69 and 25. Now, I don't really understand what that means, right? Like, we don't want to stratify.
1,000% variance.
Yeah, that's what I mean. And like, it doesn't even make sense. None of it makes sense. So we have 100% found, data-driven, that we operate better at a optimal level, which is that 25 and a little bit over range. So that's really the goal of it. Now, to get them there, everybody just assumes, well, you just take testosterone and you go there. But the minute you start taking that medication, and this is the problem with gym science, you change your muscle mass, you change your fat mass, your metabolism changes. Now the amount of muscle you have might be affecting your glucose metabolism. Now your fat intake is different, your carb intake is different. And if you don't do that in a coordinated effort, as your muscle mass and fat mass changes, your testosterone levels will go all over the map, which then affects your metabolism, right? Because the whole key to this is metabolism. So the testosterone is not what's going to hurt. That's not the issue. It's the issue of keeping the testosterone in a good level so that your metabolic energy stays right with it. And that's the biggest deal. And that's the mismatch, right? Because you have people on roller coasters that are on testosterone poorly dosed. And then over time, people just lose testosterone and become metabolically inefficient. So our whole goal is to keep that free in a place that I know your muscle mass is being supplied with enough fuel to use the carbs as an energy source and keep building on itself. And that's really the number to follow, is that free. But the adjustments to it are probably a little beyond the scope of the conversation because it gets into more biochemical shit.
And then Mike, for you, from a behavioral and training aspect, what are the things that people need to focus on? Like, let's say someone's listening and they're like, look, the idea of taking anything totally freaks me out. Yeah. So what are my controllables outside of that? That I could be doing to try to improve some of those things?
Well, one of the good things is that obviously if you have low testosterone proven by the blood panel, Marko's also going to investigate all the other levers that could be utilized so that you don't have to, especially if you don't want to go on any kind of substance, you don't have to. So the simple ones are like, okay, well, are you carrying a bunch of adipose tissue that you shouldn't? Because we know higher rates of adipose tissue actually decreases testosterone. Do you sleep well? Is your nutrition good? Do you have high stress? So like if we can clean that stuff up, most people will subjectively feel better anyways. And the symptomology of having low test kind of goes away, even if the testosterone doesn't come up like disproportionately to that subjective well-being.
Yep.
And then if you're going to go on TRT, it actually is way more beneficial if you are leaner, fitter. Like you're going to get more bang for your buck if you do TRT at some point. So I think part of it is just helping them come ultimately to the decision they have to make is like, maybe you should just get fitter, healthier, and take care of yourself, which is then a better client for Marko to treat. You know what I mean?
So Marko, you correct me if I'm wrong, because again, I'm still learning about most of this as well. It's like, so, and because one thing you said, and it made me think this, and I don't know if it's right, is like, if I'm eating like shit and I start taking testosterone, like I can make things worse. And that's really the issue. If I'm looking at, well, hey, this is going to allow me to do whatever I want, like almost like back to the enabling behavior that we did before. And in this case, we're completely wrong.
Yeah.
Right. So if I'm drinking, if I'm eating crap, not paying attention to anything, and I'm like, hey, you know what? Cause I've seen friends like where I know like they eat like crap, they're drinking, they don't sleep, they're overstressed, they're not training at all, get prescribed that. And I'm like, man, like,
is that the right call?
I don't know. Like I said, I'm not, and if they're not going to make any of those behavior changes, like you could be driving. So maybe their blood pressure was also borderline high, and now they're taking that, and that's the side effect. And now it's like to blame testosterone, and that would be totally wrong. Right. Cause it's like it could be the piece of the puzzle, but if you don't have all the other pieces, like, you don't know how we're doing.
I'm not interested in really having those people. So I don't have many. I have like two. One of which I harass constantly. I don't really feel bad about it. I constantly text him and harass him about like getting his butt in gear. Cause I also sometimes don't want that as a representation of me, right? This is my brand. Like Ferrari doesn't just hand a Ferrari to the random person. They want the right person in their Ferrari. Now, does that mean it's not accessible to everyone? No, because the only barrier to get this Ferrari is effort. If you tell me you want to do it and you show me you want to do it, we'll do it. But if you continue down the road of just doing your regular life and taking testosterone, it's a waste of my time and yours, because really you're using it for nothing, right? There's a lot of obesity in little kids. There's a lot of obese teenagers. There's a lot of obese 20-year-olds, right? They're in their prime. They probably have some reasonably good testosterone levels. I've seen obese kids with testosterone levels in the freeze of the 20s and totals in the thousands, and they're still obese, right? So it's an effort thing too. It's not just the chemical. And I think that's the biggest reason, almost going back to the initial question of why I love what I do. And this sounds harsh, but like I can ask anybody to leave if they're truly non-compliant. Like if you are not gonna follow my recommendation for landing the plane safely, well then go crash your own plane. I don't want to be involved with that, right? I know how to land you safely. I know what we need to do to get you healthy. If you're just gonna completely not listen in a voluntary situation, well then we don't really want to do that either. Like if somebody came in your facility and was like, I really want to work out, and you're like, great, let's get in the rack, you got to work out. And they're like, well, I don't really want to lift anything. I just want to like talk about it, right? Like that's not going to go hand in hand. So it's also another cool aspect to this. So I don't have a lot of those people. And I mean, one of them is a very personal reason. So I'm like, I'm fighting my own emotion about their care. So I keep harassing them because I think one day they'll break and actually get super healthy. And then the other is just struggling. You could tell. I think it'll flip. It's just more of an emotional roller coaster for them. But anybody who says, yeah, I don't want to do exercise, or I don't care what I eat, I'm going to eat whatever and drink, well, we can't really help you.
Well, I also think it brings up an interesting trend that we're seeing, or the prevalence of these, let's just call them testosterone clinics, of they have a very loose blood panel criteria. And then look at that, you're going to get prescribed testosterone. Right. So they're using the testosterone test as the litmus test if you should get TRT or not.
Yeah.
Rather than, it's one thing if it's the cause of your low testosterone, or your low testosterone is a symptom of something else. And they don't seem to care about differentiating between those two things.
Right.
Right. So if you have an obese person with terrible stress, sleep, food management, all that stuff, it wouldn't be a surprise that he has low testosterone. But it would be insane for me to say, if we give him high testosterone, all those other things get better. Right. And in fact, you probably have made that person worse by giving him access to a very powerful intervention.
Yeah,
right?
Absolutely. And the problem now, which is going to give testosterone a bad name, there'll be another cycle of bad testosterone. It'll almost be like,
no pun intended,
like steak, right? When people probably in this country first had cows on pastures, feeding them and making homemade steaks, they were incredible. Then like McDonald's and Burger King got a hold of beef, right? And kind of ruined it for a lot of people. But you can still manage to get the organic beef and that really curated beef if you really seek it out. Same thing with the testosterone, right? So there's a lot of good coming of it, but now these clinics that pop up to the McDonald's, Burger King, and they're just like, come get TRT, and they don't follow the labs and they're not medically monitored the right way. you're going to have that outfall of like something happened,
Consequence.
right? There's going to be a consequence, because even if the person was on testosterone and it had nothing to do with the testosterone, but they're not monitored, this is a new introduction of something that's going to get blamed. So I think we'll see that. You just can't one-off it. It's a medicine. It's a real chemical. It should be monitored by the right people, and you need to have expertise in the field.
And even if you just look at the example that you just gave, like how someone would start to break down what happened, right? Let's say someone starts taking testosterone, changes nothing, has a ton of other underlying cardiac risk factors, and then jumps into, like, their friend told them it'd be fun to come to a CrossFit class with them,
Right.
and then they drop dead.
Yeah.
And you're like, he took testosterone. See,
That's
he took,
exactly
he,
right.
he started taking testosterone. It's like, well, no, he had all these other underlying things that whatever that like walk-in clinic didn't screen, or they did and didn't care to, because their only goal was to sell something.
So I had an interesting conversation with somebody, an OBGYN in our area, and she's like, overthyroid can cause AFib and cause a stroke, and you'll get sued. And I was like, sounds good. We kept going. We were talking, and I loosened her up a little bit. She dropped her defenses, and I was like, well, at least I'm gonna go home tonight and have a glass of wine. I don't drink. I just wanted to set her up and see what she says. She's like, me too. So I was like, I was like, wait, hold on a second. You're gonna have a glass of wine tonight? She said, yeah. I said, so if you develop AFib from the alcohol, which is probably the leading risk factor for AFib right now, because you're dehydrated and you go into AFib, have a stroke, and die tomorrow, who should I sue? She's like, what do you mean? I was like, well, you just told me thyroid might induce AFib, so risk of stroke and lawsuit. I said, but do I sue like your husband for buying the bottle of wine? Do I sue the liquor store? Do I sue the liquor like, do you see the stupidity in what you just said to me? Right? And the best part is you just admitted to drinking alcohol. So we're already in a disagreement. She like got furious. But my whole point being, like, the effect, the direct effect on something is probably not as attributable as what you just said, right? Like, these people have so many things that they don't even know are wrong. So when they're presenting a medical history, I listen to it pretty carefully. I don't really believe any of it, because I'll know it all the minute that data set comes up. And if you really want the full picture, we can screen your heart, cancer screenings. I mean, there's ways to really investigate your body in such an in-depth, detailed look that we really leave no stone unturned.
All right. So using that as a transition, you talked about other tests and things that
Yeah.
you really get into to try to break down your full medical profile. What are some of those other tests, and what are we looking for?
Yep. So the initial evaluation includes, with that blood panel, a DEXA scan, DEXA. So it's essentially a low energy X-ray beam that will spit out information that is very accurate relative to your muscle mass, fat mass, and bone density. And then it can extrapolate visceral adipose tissue, which is called VAT. Now, that is, visceral means inside your abdominal wall, so inside the muscles of your wall around your organs. And it's fat tissue that is metabolically active, right? So it's pretty significant. It's a little different than the other types of fat cells in your body. So with that information, along with the labs and those markers we talked about earlier that are very significant for metabolic function, we can give a really solid assessment up front as to where all of that metabolism is going to go. Now, beyond that, once we get the ball rolling and people are involved in this and do want to now get as much out of it as they can, part of our program involves an RMR, which is a resting metabolic rate assessment. It gives us your total caloric needs, your carbohydrate burn, your fat burn, overall how much you would have to eat to gain weight, to lose weight, or to maintain. And then we clearly don't use just those numbers, but we can gray zone it quite a bit. And then a VO2 max, which tests your cardiovascular fitness, right? So it's essentially inhaled oxygen versus exhaled CO2. So it's the metabolism of oxygen and metabolism of carbon dioxide, but it's not true cellular respiration level. It's still at the lung level. But that extrapolation of data is significant to longevity, the number one indicator of longevity. And then a wavy brain scan. So you put a helmet on with electrodes, and we can see the metabolic function electrically and voluntarily versus non-voluntarily in your brain. I have now interestingly had about 5 people that we've been able to stop their ADHD medications relative to a finding we had on that with low testosterone and altered thyroid, and they're successfully off it. That is not a treatment protocol. I am not algorithm. Nobody please take that as medical advice, but I'm telling you, we have the ability to even intervene in things like that. So with all of that data, at least yearly, but biannually for the DEXA, definitely yearly for the VO2 or more, depending on your training. And then the RMR, depending on what phases of caloric intake you're in. With all of that together, we can consolidate information and truly be able to act on changeable items.
And as long as you can. I remember you talked about, you talked it on some of your own socials, but I know, Mike, you talked about being surprised, like, dude, we're catching people that have cancer, like in our gym. So what does that look like? Like, it was a brief clip, so I don't think I got the detail, but for anybody that's listening to this, like, what are some of those things that are coming up in that initial screening that you're like, that would otherwise not be seen for years if they're not going to go get an exam? Or
so there's an interesting thing, and this is only my opinion. I will repeat, this is only my opinion. Men have a PSA level, independent of cancer or not. If testosterone is administered, that PSA will either change drastically or not. If it changes drastically right out of the gate, I have seen now a few times where it is diagnostic of a cancer because of stimulation through now optimal levels of testosterone. So a smoldering fire now showed its flame. So I've caught now 2 because of the administration of testosterone. So the testosterone didn't give them the cancer. They already had it in them. The testosterone allowed those cells to produce more PSA, which allowed us to see it. One of which was 44 years old. His father had stage 4 prostate cancer in his late 60s. He wasn't due for his first real investigatory prostate exam till he was 50 so that they wouldn't catch it early. Thank God we caught him. He was already stage 3. He's now had surgery, treated. He's good to go. Another one, very, very similar story, had to have had a smoldering cancer for a while. We started him on therapy. We saw it, treated, fixed, and he'll be back in the system very soon. So we end up finding a ton of stuff on that lab work, lymphomas, leukemias you can look for, and chronic illness. Now, the funny thing is people say, well, you don't have direct markers for cancer in that exact panel. There are indirect markers. There's no that's cancer definitely. But what I will tell you is people with cancers in them their blood work acts funny. And it's usually noticeable through subtle changes in metabolic activity, in weight change, in muscle mass, right? Because cachexia, which is severe loss of muscle, is a pretty big indicator of cancer in late stage. Imagine if you had a random 40-year-old who then 2 years later has been training, optimized, and all of a sudden they're just losing muscle, right? Like it might trigger a thought and you might have more data to support a decision. So really the things we catch in terms of the cancers on that blood panel are more generalized, but I also offer a very specific blood draw for cancer screening specifically.
I know I had a ton of vials when that lady came to my house. So there's, I don't know all the stuff that was being checked in there, but I know whatever it was, it must have been enough because that was a lot of blood.
A lot.
Yeah. She was like, even the lady was like, what are you getting done? I'm like, whatever he said.
Yeah.
All right. So I want to shift topics. One thing right now that is gaining a lot of attention is obviously women's health and menopause related issues. I've seen you guys post more and more about that lately. I'm certainly not an expert in that at all. So, in the past, I've kind of been reliant on other medical professionals that we've been, have networked with. But as I start to see more and more information, it's like, just like anything else that we've talked about, it's like, I don't know if this shit's right.
Yeah.
Right. So like we talked about some of the misconceptions with TRT, right? Like I know what I've always heard in the news was like, hey, any hormone replacement for women, breast cancer.
Yeah.
Right. And whoever was behind the marketing of that did an excellent job because, they should get a raise because
it worked.
That is the standard. That is the number one thing that you hear. So like, obviously it's beyond the scope of trying to talk for 20 minutes about it, but give me the condensed version of why that may or may not be appropriate.
So here's the condensed version. That study was done with synthetics and bioidenticals, meaning birth control pill style estrogen and progesterone versus bioidentical, which is the exact version of it that you find in your body. It does not require metabolic breakdown to turn it into the active form. The arm of the study with the synthetic, which is what they give in birth control, OBs handed out all day, PCPs handed out all day. That's the version that caused strokes, blood clots, and cancer. The bioidentical version that we want to give to women and menopausal women in specific in the estrogen and progesterone form actually showed a decrease in all-cause mortality, a decrease in breast cancer by 30+%. And the progesterone orally is uterine protective to solve your problems with uterine cancer. So not only did the study prove that, but right out of the gate, the Women's Health Initiative, the WHI, which was released in 2002, released the data relative to the synthetic arm. So hormones caused cancer. And yes, indeed, the ones that they prescribe do, right? The ones your OBGYN pharmaceutically prescribes in the version of birth control that they hand out to teenage girls all the time before testing any labs is the version of it that causes cancer. The bioidentical version, which we use, that is the right one to use in the right places that we, as more educated, kind of deeper divers into the data, now know doesn't cause cancer. That's the version we use and has shown reduction. The problem is that WHI came out in 2002. They didn't revoke any of those statements until last year. Why? Imagine if I came out with a chemical that caused tons of cancer and I said it didn't, and I misinterpreted the data, and I'm the scientists and the PhDs that you should trust with the data. Like, you can't even think about it because you'll never read another study again. So I had to kind of eliminate that from my brain because it is so disrespectful to the rest of the doctors around them. And the fact that they haven't taken accountability to it, like the authors of that WHI that were intimately involved, 100%, it is malpractice. It's complete misinterpretation of data, and there's no other way around it. So for the layman, you've now had a world women's health initiative for healthcare completely lie to you. 10 million women that were on hormone replacement therapy went down to 0, and another 20 million women were signed up for antidepressants and antipsychotics within 3 to 5 years. Think about that. Market shift. I mean, it couldn't be better, right? If you want to funnel depressed, anxious women, tell them they're going to get cancer from the medicine they're taking. Oh, here's the drug to take for that, right? Like the best trap that was ever set. So all I would tell women is this. You can't even really blame your OB because they were trained in a very specific way, in a very specific school of thought. And within the confines of medical school in the United States, that is what's being taught, is that Women's Health Initiative data from 2002. It takes about 20 to 30 years for clinical research to become alive and used in clinical practice, right? So if you figure that's 2002, revoke 2023, it'll be about 2053, 63, somewhere in between there, where people are like, oh, all right, now we will start using that, right? So we're a little behind the time. So you can't blame the OB. You can't blame the medical schools because that's how they're built. So what you got to do is you got to just start looking at the people that might be able to provide a better experience, right? And you might have to go outside of the normal traditional medical walls to do that. But all in all, estrogen does not cause cancer, ever.
So what are, when you say that, they need to start looking outside of the realm of that, like what are, I mean, listen, I'm sure they're well aware of their own symptoms and they know how they feel.
Yeah.
Right. Like, so like outside of like that depression, all those things, what are things that they should be looking for either that would be easily identifiable that like, hey, like exploring this treatment is probably something that is appropriate because, most people are going to they have their primary care physician and they have their OB and, where does that process even start?
So in walks a 55 to 60-year-old woman, normally things that pop up are, I'm a little more tired kind of all the time. I wake up not well rested. I might sleep or I might not. Some nights I can fall asleep. Some nights I can't. I wake up at 2, 3 in the morning to pee, definitely, but sometimes then my mind starts racing. My joints don't really feel good, like my shoulders and my knees are a little achy, but I think that's old age. Bowel movements are regular. You know, I feel somewhat like I'm happy with my relationship, but like I don't ever really want to have sex. I have no interest in it anymore. You know, it's just my stupid husband. No, but I mean, like, this is it.
Yeah.
Standing in front of me every time. The biggest one to me, though, is I eat the same and I can't seem to keep off any weight, and I'm just continuously gaining weight. Now, I can tell if they're lying, but the ones that aren't, it's real. And they're trying their hardest. And it's almost kind of tumbleweeding because they're doing the wrong things. But that's the person. And then depression, anxiety, lack of motivation. There's more like severe ones because there's people that are being treated for things like that that might even be relative to hormone therapy. And then the one that we see, I mean, my most common is just, you know, I don't like feel like I really care about anything. It's almost like a lack of energy. And I say it because if your brain failed you, you don't live anymore, right? If your liver fails, you either die or get a liver transplant. If your kidneys fail, you either get on dialysis or you get a kidney transplant or you die, right? Like when organs fail, you don't do well. You got to stop looking at it like, oh, when my liver fails, I die instantly. When my heart fails, it's an acute heart attack. When your organs fail, you die. So when a woman's ovaries fail, because they do, the rest of their body starts to deteriorate and is the onset of a chronic version leading to death, right? It's a worsening group of symptoms. And now we know we can help that, right? So the person sitting across from me that says, I'm tired, depressed, I have no libido, I have no desire to even go to work, my joints are super achy, I can't lose any weight. That person now we have an option to help them with. But that's kind of your stereotypic. But the weight loss and not eating more is one of the biggest kind of trigger words that I've seen recently.
And then when you say that leads to the chronic stuff down the road, is that more so because now, like we talked about earlier with other things, like their environment sucks?
Yeah.
Like if you're tired, depressed, not sleeping, the odds that you want to wake up and eat a good breakfast and go for a walk are probably low.
Yeah.
So it's like we talked about before, it might not be this one thing actually like causing it directly, but if now all that cascade of hormones and all those things that are screwed up make the likelihood that you're going to do any of the other shit that you should be doing low, well, now you're going to suffer all the side effects from that.
Like people have trouble quitting booze, cigarettes, any bad habit, whether it's good or bad. It's tough to quit something. Imagine your body was high on hormones like estrogen and all that. That's why young women, they feel great, 20s and 30s. Libido's great, energy's great. They're out there, right? Like they're in the world. And then all of a sudden, you have to forcibly quit that drug called estrogen, right? It's damaging. You're a completely different person. And I always tell people this. The funny thing to me is, I have this argument with obese too. You drink coffee, if you're a coffee drinker, you're used to caffeine or whatever it is, whatever version of caffeine. If you try to stop one day, bang. Or like randomly for a week, you're like, I'll have a coffee here and there. And you don't have your morning, your afternoon, and your evening up and low and cycle of coffee and caffeine to keep you going. It's the same as estrogen, right? So that caffeinated person, you turn it off. They're a different human. That estrogen cycle every month in a woman keeps them alive. That keeps them who they are. The minute you shut that off, their entire body changes. And we only know what we know, right? So we know it makes them change in the data sets we have, but there's probably things we don't know going on in the body and chemicals we don't know because we don't know how to find them and things happening. But overall, if you shut an organ down, you know, that person's gonna be different.
So one overarching question that I think applies to any of these interventions that I know people bring up, and I know I have my own thought process of how I've kind of gone around it, but like, I try to look at it like, it'd be a little bit off topic, but like, it's a little bit like religion, right? Like a lot of people will be like, hey, like only dumb people, believe in that. And then other people will be like, but then I know a lot of smart people that are, that are educated and do that as well. So it's like, I've had, I have a lot of people that I would consider friends, colleagues that I consider be really intelligent and, would be on board with this. And then I have people that I consider be really intelligent that would be off board with it.
Yep.
So there's something different. It can't be just the information and data that is driving these decisions, because there's people on both ends of the spectrum that are pro and con, and one of the arguments that I always hear from a lot of I don't mind to use names, like someone like a John Berardi, right, would be like, hey, look, how are we not so sure that all of this is supposed to be just a part of the aging process, right? And I'm not saying I have an opinion one way or the other, but just from your aspect of being involved with it, because those are the ones that I know, because it's not what I do for a living. I don't have a good counter argument, right? If someone's asking me
here's my counter.
I'm like, I have no idea how to answer that for you, right?
My counter argument: would that person like to be alive in like the 1600s?
Probably not,
because that's how life was supposed to be in the 1600s. And then in the 1700s, you were supposed to die when you were like 20. The average life expectancy in the early 1900s was like, I don't know, like 40 maybe 35. Or something. You know what I mean? Like, I don't know. The minute somebody says that that's naturally what's supposed to happen, I immediately, I'm sorry to say, I can't reason with that. Because all that does is just say, fuck it, let's see what happens. And we're supposed to kind of live to 60. Well, if you were alive in 1900, you thought you'd only make it to 40.
Sure. Yeah. So
he wouldn't even be allowed to express that opinion right now. He'd be dead.
So that's why I always as an intermediary, it's like, hey, look, that's people's opinions or whatever.
Yeah, of course.
So because I look at it as I'm always an intermediary with a client, right? Because regardless of whether I have the actual knowledge or not, a lot of times people are going to come to me and be like, hey, well, what do you think? I'm like, well, if you're relying on me right now, I'm going to have to refer you to someone else. But it's helpful to be able to have those conversations and try to explain hey, because the issues that we're dealing with, we never got to before. We've reached a new level. So new levels require different ways of thinking or approaches to handling
and that's the biggest thing. It's in any world, if you can't make the change yourself and you have an ego that you don't want to ask for help, you're just going to tell people this is the best option, right? Mm-hmm. If you went to a Ford dealer and they really want to keep you there, they're not going to tell you oh, by the way, Jeep down the street makes a little better version of this. So for your family, that's going to be better. No, they're going to keep you in the Ford. So maybe that person's ability to enact change on that human's life to extend their life was zero, because all they had in their tool set was what they had. And beyond that tool set, they had to ask for help. But that's relatively not a good thing to do if you're not willing to promote somebody else's skill set. I only know my skill set extends to what it extends to, and then you have to go see Mike for the training. I can't build your program. So I think allowing people to know that next extension of that model is available. So you don't need to tell anybody any data on anything for life extension, for medication like that. All you need to say is, hey, here's an option of somebody to go speak to. Because the minute they can sit in someone like my office, I will overwhelm them with data. And it is not marketing. We actually do the opposite, I would say sometimes. We market ourselves, but we're in a gym. There's people lifting weights. I get comments all the time. I don't want to go to a gym to see a doctor. But we make your barrier to entry to get in to see us very difficult. Why? Because I don't really want you walking in if you're just looking for a quick fix. We want that all consumed. But the best thing, I think the reason this all started was, as long as you know that next option is available, I think that's something really reasonable to hand people to. Now, and you need to vet that next option, but as long as they know it's available, it's a big advantage.
And I would say, when people, I've heard that argument too. It's what's natural. And that's what I would start with. What do you define as natural? Because if we can't agree to terms, then we're always going to disagree. So is it what we live in right now, God's plan, or is it natural? If yes, then it would make sense that now we have a way of obviating some of the aging process. If not, then you shouldn't use your cell phone and you shouldn't use your microwave and all that other stuff. But I would kind of end with the idea that, and I forgot who said this, but the true mark of intelligence is getting out of life what you want. And that's like, it's your decision to pursue this or not. And that's why we are elective based. Like you have to, elective meaning you are committing to this. You're making a conscious decision that this is how you want to live, or this is going to afford you the way that you want to live. And that's it. And if it's not for everyone, it's not for everyone. But then that's probably the only natural thing about it, is that you get to choose with an informed decision if you're going to pursue this or not.
Makes sense to me. Yeah. And like I said, like I look at this stuff, like when I'm trying to gather information, is that, how it's my job, at least I feel like it is, to understand both sides of it, right? Because then I can have a better
100%.
conversation. Because then, I can be a better intermediary and answer some questions, at least enough to get me to the next level of the conversation. Because sometimes in my perspective, like, we have a shared, maybe a couple of shared clients now.
Yep.
And, the conversation from one of them was like, hey, go talk to Marko. Okay. Right.
Yeah, right.
And then another one was like, all right, like I have to, there's months of like,
Yep.
hey, look at this clip from Marko. Hey, like, what do you think about that? And like, I have to break down that wall, like even to get because, for me, it's like, I just got to get them into the room. And I know if I can get them in the room, then the change will probably happen.
Yeah.
It's not apprehension of wanting to do the actual task. Like, the tasks I'll do, right? It's, do I even like want to do the tasks, right? Like, I have to be able to want to do the tasks first. I'm trying to oversimplify that, but yeah, that's why I'm always trying to gather information on, multiple sides of this, so I have better answers to try to explain to people when they ask.
And I think that the best thing too is, like, it is good to have information. It is then good to say, hey, talk to this person. It's also good to tell them, like, meet him. If you guys get along, it's great. If you don't, and have options, because am I the perfect fit for everyone? Maybe not, but we could maybe get you in the right spot. It's just like medicine's like anything in life. You have a painter come to your house, you want to try to get the best one at the perfect price, right? So there's always that budgeted into decision making. But the biggest thing is just information, right? And we got to just get it out there. And that's why I have no problem doing these things. Like, some people are like, well, you tell everybody what you do. It's like, well, I don't really care, because if I hand you the same stuff, you just can't do it, right? Like, I have people all the time tell me, like, well, I'll just go buy the stuff somewhere else and do it. And I say, great, no problem.
Yep. I mean, like, the example I give is, like, I talked about my, for someone who's otherwise healthy, like, even the review of my blood work was over an hour. So,
because there's always something,
other things to fix.
There's always ways to get better. Like, there's very few people in the world that get 100 on every test they take, right? Like, so if you don't, then we can always improve. And does it mean you have to be perfect? No. At least just try to be a little better.
And then just trying to figure out what that driving force is for everybody. Yeah. Like, for me, it was like, I didn't have my daughter until I was 40 almost. So like, if I want to be hanging out at 70 and 80 and not just being wheeled around, like, I gotta, that was the one last topic that I wanted to bring up, is like, people don't look at these numbers, like they're moving numbers, right? If I'm watching a roller coaster go by and I take a picture, I'm like, oh, look, it's at the top, right? Like, well, in 30 seconds, it's going to be going down really quick, right? So trying to get them to understand that, like, there's a normal degradation process to all of these things. You are going to lose, I don't care who you are, you are going to lose bone density.
No matter what.
You are going to lose muscle mass. So if we're trying to back ourselves in to this at 75 or 80, what you have right now, although normal, right, is not enough, because if you start degrading tomorrow, right, then you're going to be below what you need to be. If going for a 5-mile hike is an activity that you want to be able to do when you're 80, well, then you should probably be able to handle a 15 one with a 20-pound weight vest now, because it's going to go down. I don't care. You could be the fittest person in the world. It's going down.
That's right.
So,
and eventually that is going to shift into pediatric population too, because it's just like a building. Like, your facility's getting all built out right now, right? When you go into a building being built, the workspace is crazy, right? There's dirt, there's nails, there's dust. That's a little kid's body, right? Like, their metabolism is firing off so fast, they're building shit so rapidly. I'm convinced, this is another one of my opinions, like, once we start figuring that age group out, a lot can change, because cancers and diseases, a lot of them are from replication of cells that goes uncontrolled or unchecked. Well, at what point in your life are your cells replicating the most, right? When you're young. And we miss a ton. And then we call it rare disease. we're just not good at accountability in the medical world because hospitals and doctors in general haven't said to the population yet, hey guys, we really don't know a lot, but here's what we know. And we're going to try to work with this and expand our knowledge. Instead, they say, super duper high tech, advanced everything. We know everything. We'll cure we haven't cured anything except for smallpox, one disease on this planet. Otherwise, everybody dies, right? We all die. There's no way to avoid it. So if you take on the task of longevity in the back of your mind with how we can change your day to day, I then believe you have a fighting chance to extend your life with good quality. But if you can't come to grips with that and embrace the fact that we really do have a timeline we need where entropy takes over and we do have an end result, until you embrace that, you can't embrace the acute care day to day for the maintenance, right? Like you have to come to grips with that. And the medical world just can't. I mean, so many times I used to meet with patients and they're like, oh, the doctor before you came in and said we should operate. I'd go in and be like, listen. And I'd say this just like this every time. I'd say, yes, I can go in there. I can put you to sleep and I can cut you into as many pieces as we need to make sure that the time frame of that operation looks reasonable so I get paid. You will then just have a bunch of scars on you and the change in your life will be minimal, if not worse. But the system is so determined to prove that we can solve every problem that they're willing to intervene on almost everything. And it's kind of a sad dynamic because now we're fighting that really hard by saying, hey guys, like we can extend your life. And it's gonna work because every example they've seen was that. Like, well, got operated on 8 times and still died, right? Like, so they're not seeing the good things. But if you take a healthy guy, like I could take Mike right now, put him to sleep, wake him up 50 times and probably cut little things off of him, he's gonna be fine because he's healthy going into it. You gotta remember those people are not healthy going into a situation and offered a false hope. So I think you got to set the standard. Longevity in the back of our head is a goal, but quality is the primary. And we do have the tools now through technology, through data, through the advancement of medicine to help you improve that over time.
Yep. And I think from an end user standpoint, the focus becomes on all the things that we don't know.
Yeah.
And then not doing anything. And then instead of like leaning into like, no, we know a good amount that can keep you, that is within your control. And then they just get lost in a sea of information.
Yeah. And the other biggest thing is like, we are linked, right? Like we are linked. So your clients that see me are already in the exercise nutrition world. So if we remove that, medicine's useless. And I will stand by that. I'm not trying to get people to go to see trainers. Do what you want to do. But the point is, if you're not doing that, essentially all of what I'm doing is relatively neutral in terms of effect.
Makes sense. All right. Well, this has been about 2 hours now, which was
lovely.
A good amount of time.
Awesome.
I feel like we covered a lot of stuff. Everything was super helpful. I obviously anybody that I'm going to directly refer, I will put you in touch with. But any listening to this that is interested in your guys' services, where can they find you?
So on Instagram, we have a pretty good presence at Ranfone Training Systems, at Michael Ranfone, at Lujic, RTS Health, Lujic MD _ RTS Health. We have a new PA, Kathleen Kelly, and our practice is very accessible online. Email would be rtshealth@rtsct.com.
Or the website too is pretty information packed. So if you want to kind of get a better understanding of options, rtsct.com is both our websites. So
yep, and we'll link all those in the show notes, so I'll be good to go there.
Lovely,
cool. Yeah, appreciate it, man.
Anything else?
No.
This is awesome.
Yeah,
Thank you.
Thank you.